So today we will be discussing about pelvic organ prolapse. So as you can see in this picture here, that the bladder, uterus and rectum, all the three organs, they are steadily standing on it. So how do you think this is happening inside the body? So there is something called as the supports, like the ligaments, fascia and the muscles, so which help in holding all these viscera in place in the pelvis and to the pelvic wall, right? So today we'll be discussing about pelvic organ prolapse in detail. Hi everyone, I'm Dr. Sneha Purankar, working as Senior Registrar at KIMS Hospital, Secunderabad. So today regarding genital prolapse, we will be seeing a detailed overview of prolapse, the clinical examination and the POPQ staging. Even though it is a difficult one, I'll try to make it simpler as much as possible. And regarding the management and prevention of the prolapse. So prolapse overview, so it is defined as herniation or protrusion of the pelvic organs into or outside of the vagina due to failure of the anatomical support. Or simply it can be called as the downward displacement of pelvic organs. So how does it result? So it results from the weakened pelvic muscles and connective tissue. As I told, all the organs or the viscera are held in pelvis because of the supports. So due to the weakened support, and it is also seen commonly in the multiparous and the postmenopausal women. So not it's not just like it is seen only in multiparous or postmenopausal, but it is commonly seen in them. It doesn't mean that in nulliparous women you cannot see the prolapse. You can see prolapse in case of a nulliparous woman also. So before going in detail, we should know the pelvic floor anatomy. So as you can see in this picture, this is the anterior aspect and this is the posterior. So this is a pubic symphysis and here is the sacrum, right? So this is the urethra, this is the vagina and this is the anal canal. And surrounding these, you can see some fascia and the muscles. So we'll see what are those. So here you can see surrounding the urethra is the urogenital diaphragm, okay? And here surrounding the vagina, you can see the levator ani muscle. So levator ani muscle is made of the iliococcygeus part. So it attaches from the ilium to the coccyx. And it is the pubococcygeus muscle, right? And here you can see a blue fascia. So this is the arcus tendinous fascia of the levator ani, okay? So this picture is in detail. So this is the pubic symphysis here and this is the posterior aspect with the sacrum and the coccyx. So same thing, this clitoris, the urethra, the vagina and the anal canal. So now you can see surrounding the clitoris is something which is called as the bulbospongiosus muscle. And here is the ischiocavernosus muscle. So there is something called as a perineal membrane. So superficial to the perineal membrane, there is superficial perineal pouch and deep to it is the deep perineal pouch. So the superficial perineal pouch contains all these structures. And here you can see something surrounding the, here, this is the transverse perineal muscle. So transverse perineal muscle is also superficial transverse perineal and deep transverse perineal, right? And here you can see the levator ani muscles. So the perineal body is here. So it is a conglomeration of 10 muscles, out of which the main muscle is the levator ani. Okay. So now we'll go in detail about the pelvic supports. So supports of the genital tract. So it was De Lancey who introduced 3-level systems of support. So it is the level 1, level 2 and level 3. So this level 1, as we have discussed earlier, contains the ligaments. So uterosacral and the cardinal ligaments which support the middle or the central compartment, that is the uterus and the vaginal vault. So these ligaments are nothing but these are the condensation of the endopelvic fascia. Uterosacral ligament is a condensation of endopelvic fascia, right? So these ligaments will form the level 1 support. As we know, the uterosacral ligament connects the uterus to the sacrum. And cardinal ligaments, they hold it to the pelvic wall, right? Cervix to the pelvic wall. And level 2 will consist of the pelvic fascias and the paracolpos, which connect the vagina to the white line on the lateral pelvic wall through the arcus tendinous. So as you have seen in this picture, this is the arcus tendineus. Okay. And next is the level 3 support, which is the levator ani muscle we have seen in the picture, and it supports the lower one third of the vagina. So these are the levels of support as seen in this picture also, level 1, level 2 and level 3, right? So ligaments, fascia and the muscle, they form level 1, 2, 3 respectively. So now, what are the types of genital prolapse? So now that you have understood, prolapse is nothing but downward displacement or herniation of the viscera into or out of the vagina, right? So what are the types? Now we know that it is divided into 3 compartments. So it is the anterior, middle and the posterior compartment. So anterior compartment comprises of the bladder and the urethra. The middle compartment, it comprises of the uterus, vagina, and some part it is the intestines also, upper one third they herniate through the central compartment. And posterior compartment consists of the rectum. So cystocele is something which is the herniation of the bladder, and rectocele is the rectal bulging. Enterocele is the small bowel herniation. Uterine prolapse is the condition where the uterus descends down, and vault prolapse, usually you see it after hysterectomy, where the vault will come descend down. So these pictures are clear here. So in this you can see the cystourethrocoele, right? So this is the bladder which is coming down. Here is the rectocele. See the rectum which is descending down. Enterocele, the small bowel. Here there is herniation of the small bowel, right? And this is the uterine prolapse. You see uterus is descending down, and this is procedentia. Procedentia, as we know that the complete uterus is outside the vagina. Okay. So classification. There are many different classifications, out of which I have mentioned these. So it is Shaw's classification, Baden-Walker system and Jeffcott's. So we'll see about the Shaw's and the Baden-Walker, which are most commonly discussed. So Shaw says the classification of prolapse according to the compartment wise. So it is the anterior vaginal wall prolapse. As I said, if it is upper 2/3, that is there is a bladder herniation. So that is cystocele. And lower 1/3 herniation, I mean coming down, urethrocoele. Together, if both descend down, it is called cystourethrocoele. And if it is a posterior vaginal wall herniation, so if the upper 1/3, it will be the enterocele, which is nothing but the pouch of Douglas hernia, and lower 2/3, it is the rectocele. So what about the uterine descent? That is the apical thing. So it is classified into 4 degrees, the uterine descent in Shaw's classification. So first degree will be the descent of cervix in the vagina. So it is in the vagina, the cervix is in the vagina. And second degree, the descent of the cervix up to the level of the introitus. As you can see here, so this is normal, there is no prolapse. Here the cervix has come into the vagina. This will be the first degree. Second degree, the cervix has come up to the introitus. And third degree, descent of the cervix outside the introitus. You see, it has come outside the introitus. And procedentia is where the uterus is completely outside the introitus. This is procedentia, Shaw's classification. So there is something called as the Baden-Walker halfway system. So here, everything is told in relation to the hymen. So you consider this is the hymen, right? So everything is told in the halfway system. So this is the cervix here, and this is the level of the ischial spine. So we know that the os is at the level of ischial spine. So you consider if the cervix is here, there is no prolapse, which is grade 0. What about grade 1? So grade 1, it has come halfway to the hymen. So it has come till here. The hymen is here. It has come up till halfway to the hymen. That is grade 1. And grade 2, it has come till the hymen. This is grade 2. And grade 3 is halfway past the hymen. And grade 4 will be the maximum descent, like completely outside. This is the Baden-Walker halfway system. So now we have known what is prolapse. So it is the downward displacement of the pelvic organs because of the weakened tissues. And we have known the classifications, the gradings, and what are the different types of prolapse. So now what are the conditions which will lead to all these things? So there are certain risk factors. Okay. So first is multiparity in the vaginal births. So multipar is, more than the woman bears many children. So that to vaginal births, that will be the problem. And this can lead to prolapse. It will be one of the risk factors. Not that every multiparous lady will develop a prolapse. And next risk factor is the menopause. That is Because menopause, what happens? There is a decline in the estrogen, we know. But what is the relation between estrogen and the prolapse? Now we discussed the supports, right? The ligaments and all. So they contain the estrogen receptors. In menopause, when the estrogen declines, obviously the receptors do not have estrogen, and then they start getting weakened. So in menopause, that is why you can see more prolapse. And certain conditions like chronic cough and constipation, they increase the intra-abdominal pressure, so which can lead to prolapse. This will be a risk factor. And obesity is a risk factor because in obesity also there is an increased intra-abdominal pressure, and also it will decide the recovery from the surgery also. And history of prior pelvic surgeries and congenital weakness can also lead to prolapse, where there is a congenital weakness in the connective tissues. For example, conditions like Marfan's and Ehlers-Danlos. So now you know the risk factors. And how do the patients present? Patients with prolapse present. So they come to you saying that I have some dragging sensation or some heavy sensation, and there is a visible mass at the introitus. So they tell you that there is something coming out of the vagina. So there can be any urinary incontinence or retention also. And complaints like constipation. So what are the urinary complaints? So they can be frequency, urgency, incomplete evacuation, constipation, dyspareunia, or any sexual discomfort. Complaints can also be there. Now, how do you diagnose prolapse? So, the first and foremost important aspect is by taking a proper history. And then you go for the clinical examination, which is general and pelvic examination. And then you do a POPQ classification. Ultrasound, not for every case, but for a few selected cases, you can do. And then you assess the pelvic floor tone. So approach to a case of prolapse with history taking. I'm not going in detail about history taking because I'll pertain to the points regarding the prolapse, right? So when you take history in prolapse, the introduction parts, the age is an important thing. So age, menopausal status. Now we have understood that menopause is a risk factor. So has she attained menopause or not is important. Certain people are less than 50 years, but still they might have attained menopause. So for them, the period of menopause will be longer. And parity, obviously, multiparous ladies are at risk, and occupation. So any occupation which is related to heavy weight lifting or after surgery, if there is any recent change in the occupation, all this can decide the recovery of the patient. And chief complaints, duration of the symptoms. So if you have seen in your OPD, not not many women come to you right at the moment where they see the mass out of the vagina. So there will be some conditions which will lead them to come to you. For example, if there is any worsening of the symptom, or it's been there since chronic time and all of those. So definitely you should mention the duration of the symptoms and ask what is the reason for presentation now. And symptoms, you should ask both positive and negative symptoms. That too, you should ask compartment wise, that is anterior, posterior, and apical compartment. So anterior compartment regarding the bladder, the voiding complaints, or are there any obstructive complaints? Like is there any frequency, uh, urgency, and does the urine leak when she's coughing, straining, or lifting heavy weights? Okay. And the posterior compartment, same. Is there any increased frequency of stools? Is there any flatus incontinence and incomplete evacuation of urine or stools? And apical compartment related, you should ask if she is having any mass, swelling, mass or swelling, if there is any discharge, bleeding, or any ulceration. And in obstetric history, should specifically ask if she had delivered any big baby, had she had any instrumental delivery, was there any prolonged labor, medical and surgical history. So medical history, certain cases of diabetes, a prolonged diabetic, long-standing diabetic can have myopathy and neuropathy. So such conditions can lead to weakness of the tissues and lead to prolapse. Not so prolapse can be due to the general condition also, not just the weakening of the supports there. And surgical history, past surgical history, like if she had hysterectomy, then you can see whether it is a wall prolapse or something. So in general examination, specific points to prolapse, you should definitely mention the body mass index, that is the obesity. It will decide which class of obesity does the patient come to. And definitely the gait or walk of the patient. So in certain neuromuscular conditions, some bone and joint problems, the gait can change. So such conditions can also lead to prolapse. not only the local causes. So you should examine for the supraclavicular lymph node because we know that the abdominal pelvic malignancies, there can be metastasis and that can present as a enlargement of the supraclavicular lymph node, particularly left side. So some abdominal pelvic malignancies can also lead to increased inter-abdominal pressure leading to prolapse. So prolapse, when you see a case of prolapse, it's not just because of the local thing, that is a weakening of the support, but you should rule out other general conditions. And definitely auscultate for the chest because any chest malignancies can also cause chronic cough, it can lead to chronic cough and then prolapse. So if there is any ascites or the abdominal mass. So now the clinical pelvic examination, we know we have to divide it into inspection, palpation. So in inspection, what do you see? So you look for the pubic hair. How is the local health? And are there any signs of excoriation? Because usually prolapse, long-standing prolapse patients can have urinary complaints also. And because of the chronic problem, it leads to the excoriation of the skin and leads to white patches. So you should examine for that. And look for the health of the vulvovaginal tissues, whether they are pale or well estrogenized. Look for the vaginal rugosities and look for the mass. So usually they come with the complaint of mass. So you should describe the mass. How is the size, shape, and how is it presenting on the cough impulse, and external laws, how is it? And then you have to look for any ulceration, erosion, keratinization, or pigmentation of the mass. So you look for any previous scars or sinuses because of episiotomy, there is any scar, or prior pelvic surgeries, any scar is there. So when you know that when you ask the patient to do coughing, bed on, or do a Valsalva, the pelvic floor mass increases in size, and then you can see it properly. And in inspection, you should ask you should also demonstrate for the stress urinary incontinence. Ask the patient to cough and look for the urine leakage. So here in this picture, on inspection, what do you see here? You see a mass protruding through the vagina. So there is no external loss, mostly looks like a vault. This you can see the dimpling here. So mostly this is the vault. So you can describe on inspection, you can describe the size, shape of the mass, if there is any ulceration or induration, which we have discussed prior. And this image, so you can see there is a mass protruding out. You can see some blackish area. This is the keratinization. And here you can see something called as the ulceration on the mass. So these all you can see on the inspection. And here you can see signs of excoriation. So you see the whitish patches here. So because of the urine leakage constantly, it leads to excoriation of the skin. So palpation. Now let's see about the palpation. Now in inspection, you have seen a mass coming out. So you can see if there is any get above the swelling. So what is the point in get above the swelling? So if you can go above the swelling, it means it is mostly the uterine mass. But if you do not, if you feel a tubular structure, you cannot go beyond the mass, usually it is because of the cervical elongation. So you should know that the protrusion of the mass or the swelling or the prolapse can be due to cervical elongation also, not that the whole uterus is outside, right? And palpation, look for the external laws because the position of the external laws will tell the extent of the prolapse, like whether it is more anteriorly or posteriorly. And cervix also look for the cervical elongation. And then you, look for the ulcers there, any local ulcers, whether it is indurated or not, or if it is a bleeding on touch. And palpate for any other masses. Look for any adnexal masses or something. And then you do the speculum examination. So speculum examination should be done after repositing the mass. You place back the mass inside and then you ask the patient to bed on or cough and look for the mass. So in order to look for the anterior, you should look for the compartment wise, anterior, apical and the posterior compartments. And after repositing the mass, you should look for the stress urinary incontinence. So all those findings which you have seen in inspection should be confirmed on palpation also. So yes, so here you are palpating. Here you can see that we can have a get above the, there's no get above the swelling. So mostly this looks like a cervical elongation. And then here you look for the keratinization and feel for the external laws, the ulcers and everything. So here you can see there is an ulcer. Okay, palpate for that. And this then comes the speculum examination. So like I said, speculum examination should be done compartment wise. So in order to look for the anterior compartment, you can use a Sims double bladed speculum. So the speculum should be placed into the posterior vaginal wall, so you can visualize the anterior vagina properly. So place the speculum here and look for, ask the patient to bear down, and you should note what are the defects, like whether it is cystocele along with cystourethrocoele or what other thing. And then this is for the apical or the middle compartment. For this, you should retract both walls, both anterior and the posterior vaginal walls, and look for the cervix. And then you ask the patient to cough or bear down and look for the swelling. Okay, and here you are looking for the enterocele. Okay, you push the cervix also and then look for the enterocele here. And this is how you examine the posterior compartment. Place the sim speculum and retract the anterior vaginal wall. Look for rectocele, okay, or any perineal defect. So in this picture, you can see some swelling in the anterior compartment. So you place the speculum in the posterior vagina and you can see the bulging of the urethra and mild cystoceles you can see. And here you can see the rectocele also. Now you have placed the retractor in the anterior vagina, retracted the anterior vaginal wall and seen the posterior compartment. So in palpation, you have done all the things described earlier, and then reposit the mass back, and go for the bimanual examination, where you have to assess the size of the uterus, the mobility, the adnexal mass, and look for any cervical elongation. Also, the reflexes are important. So there is something called as the anal wink reflex and the clitoral tap. So when you just do a wink at the anus, you can see the contraction of the sphincter. And what does it indicate? It indicates that the neuromuscular integrity of the perineum is intact. And then you should assess for the tone and strength of the pelvic floor musculature. So there is something called as the modified Oxford grading for the tone of the pelvic floor musculature. So how do you assess the tone of the pelvic muscles? So one or two fingers, they're kept inside the vagina up to halfway, and with the help of the thumb, you have to hold the bulk of the levator ani. So you assess the tone at both sides. So one side it is from 7 to 10 o'clock position, and the other side it is from 2 o'clock to 5 o'clock position. So here, this picture shows how do you assess for the pelvic floor tone. So index finger inside the vagina and the thumb here. So this is how the tone is assessed. So the muscle is actually slipped in between the thumb and the index finger. So you assess the resting tone, contraction, okay, and then grade. So what is the importance of the tone of the musculature? According to this, you will understand whether you can train the patient in pelvic floor muscle exercises or post-op recovery, whether she will be doing Kegels and maintain the tone. And in in the palpation, you should go for a rectal examination as well, and it should be a single digit examination. So you have to confirm the sphincter tone. You have to confirm the rectocele. So rectocele, you can see it in palpation itself, but how do you confirm it? You can confirm it by doing a rectal examination. So the defect of the rectocele bulges out. The index finger will bulge out if it is a rectocele, and you can differentiate it with enterocele in a rectal examination. In case of an enterocele, there is no bulging of the finger. Okay. And then we have come to the POPQ staging. So the ICS and the AUGS societies, they have come into an agreement for a graded objective measure to be used in the assessment of the female pelvic organ prolapse. So this was named as the POPQ system, that is pelvic organ prolapse quantification system. Okay. So how do we use the POPQ? So POPQ, there is can be like there are 4 steps. One is the pre-examination. Then you what are the measurement parameters you should know, and then recording the measurements, and then how do you stage the prolapse. So pre-examination for POPQ. This is for POPQ. So patient should empty the bladder, and if feasible, she has to empty the rectum. And then what about the positioning? In which position you have to see? So the position should be such that the utmost magnitude of the prolapse is shown and can be confirmed by the patient. Okay. So this could be in supine, because the mass comes out properly to full extent in a supine position for someone, and for some people in standing position. Okay, so then you use a sim speculum to draw back the anterior and posterior vaginal walls during the examination. And all the methods and positions utilized during the examination should be documented so that they can be reproduced. So what do you use to take the measurements? So you can use a graduated air spatula or anterior vaginal retractor which is graduated, or a specific scale called POPQ scale which is available. So now the examination is done, and what are the measurement parameters? So first, see this image. So this is the hymen. So the hymen, the plane of the hymen is taken as the 0, right? And any other measurement which you are taking and it falls into above or proximal to the hymen, it is taken as a negative value. And below or distal to the hymen is taken as positive. So anything above or proximal to the hymen is negative, and here it is positive. So the measurements are like, they are made up of 6 distinct locations. So that is the AA, BA, CD, AP and BP. And there are totally 3 measurements also. So 6 points and 3 measurements. Now let's see what are the 6 points and 3 measurements. So first, it is always easy to know the 3 measurements. Okay. So first is the genital hiatus, next is the perineal body, and it is the total vaginal length. And this point AA is the A point in the anterior vaginal wall. BA is the B point in the anterior vaginal wall. And C is nothing but the cervix or the cuff in case of a post-hysterectomized patient. What is AP? It is A point in the posterior vaginal wall, and B point in the posterior vaginal wall is BP. And D is the posterior fornix. So D is not taken, the measurement is not taken in cases of post-hysterectomy patients. Okay. So now what are the points and where are they specifically located? Let's go and see it. So this table shows first point A point in the anterior vagina. So this is a fixed point. You know that it is a fixed point in the anterior vaginal wall, and it is 3 centimeter proximal to the hymen, right? So this is the AA point here. This is the hymen, and 3 centimeters proximal, that is here. Proximal to the hymen, it is taken as the AA point. So what is the range? So now it is 3 centimeter proximal. You know that it is minus 3 centimeters, and maximum value can be plus 3 centimeters for AA point. Now BA point, B point in the anterior vagina, which is here, right? So this is nothing but the most distal portion of the anterior vaginal wall when the patient strains. So the most distal edge when the patient strains will be taken as the BA point, and it ranges from minus 3 centimeters to plus total vaginal length. And then the C point. So C point is here. You see the most distal edge of the cervix or the vaginal cup scar. This is the C point. And D point is the posterior fornix here. This is the D point. This D point is not there in case of post-hysterectomy patients. And A point in the posterior vagina, that is 3 centimeter proximal to the hymen in the posterior vagina. So this is the AP here. So 3 centimeter proximal, and in the posterior vagina is the AP point. What about BP? So it is the most distal portion of the posterior vaginal wall when the patient is straining maximum. So here is the BP points. So when there is no prolapse, AA and BA correspond to each other, that is they remain at minus 3. And AP, BP also remain at the same place, that is minus 3. So the BP, BA points change when there is a case of prolapse. Okay. So the value, the maximum range for BP is also minus 3 centimeters to plus total vaginal length. So now let's see the measurements here. These are the 6 points and these are the 3 measurements. So it is the genital hiatus. So this extends from the midpoint of the external urethral meatus to the posterior midline of the hymen. So here you see this is the midpoint of the external urethral meatus, and this is the posterior midline of the hymen, right? So this is the genital hiatus. This is how you measure the genital hiatus. What about perineal body? So it is measured from the posterior margin of the genital hiatus to the middle of the anal opening. So this is from here. the posterior margin of the genital hiatus to the mid-anal opening is the perineal body. Here you can see the perineal body measurement. Total vaginal length, it is nothing but the depth of the vagina when point C or D is reduced to normal position. So TVL, this is the total vaginal length, right? This whole thing is the total vaginal length. So one important point you have to understand is that all the measurements, that is the 6 points and 3, only the total vaginal length is taken when the mass is reposited back. Rest other measurements except TVL, except TVL, all other measurements are taken when the patient is straining maximally. When the patient is straining maximally, only TVL is measured when the mass is reposited back and patient is calm, relaxed. So this is a line diagram which tells you about the measurements again. So AA point, BA point, AP, BP, genital hiatus, perineal body. Okay. So these could be the values, POPQ values in a normal lady when there is no prolapse. So AA is at -3 and BA is -7, AP is -3, BP is -7. Yes, TVL should be 9 to 10 centimeter. Okay. So pre-examination is done. You know that patient should empty bladder and what measurements you should take, 6 points, 3 measurements, that also you have known. And what are the specific anatomical areas of that points. And now how do you record the measurements? So after taking the measurements, if any point out of the 6 points, it drops to the hymen. So now we know that we have taken hymen as the reference point. So hymen is taken as 0. Right? So hymen, it is measured as 0 centimeters. So if it stays higher than the hymen, that is proximal to the hymen, then that value is taken as a negative value. And if it protrudes past the hymen, that it has crossed the hymen, then it is taken as a positive value. And all the measurements, they are recorded in centimeters. Okay. So now we will see how do we take the measurements of the measurements and of the 6 points also. How do you take it? So this is a spatula and it has some markings on it. So you can make markings on it. You can use this or you can use a graduated anterior vaginal wall retractor, or there is something called as a POPQ scale also. Okay. So the first measurement, always it's better when you start POPQ, it's always better to go with the middle compartment first. The middle row. These are easy to measure. So first we'll go with the middle row and then go with the anterior wall measurements and then go with the posterior wall, right? So this is the genital hiatus. So you know that genital hiatus is a measurement from the middle of the external urethral meatus to the posterior midline hymen, right? So you measure it from the external urethral meatus to the posterior midline of the hymen. So this will be the measurement for the genital hiatus. So this all, one thing is that first you locate the point and then you ask the patient to push and then you measure. So locate, ask the patient to push and measure. This, if you follow this, it will be easy for you. So first locate where is the point, ask the patient to strain and then you measure, except for total vaginal length. Okay. So this is how you measure the perineal body. So it is from the midline of the posterior hymen, that is midpoint of the hymen, to the midanal opening. This will be the perineal body measurement. Same thing, perineal body is also measured like first you locate the point, ask the patient to strain and then you measure. So this is the total vaginal length. This is measured when the patient is not straining. Okay. So total vaginal length you measure. Okay. And then let's see the anterior, the first row. First row, AA point. So AA point, you know that it is a fixed point on the anterior vaginal wall, 3 centimeters from the external urethral meatus. So first you locate, this is external urethral meatus, then you take 3 centimeters from this. And then you mark on the anterior vaginal wall. And then you ask the patient to strain. First you located it, then ask the patient to strain. And then you measure the value from the hymen. How much is it corresponding from the hymen? Okay, this will be the AA point. Similarly, BA point. So BA point is the most distal edge in the anterior vaginal wall when the patient is straining. And then you take it from the hymen. So always remember, all the measurements are taken in reference to the hymen, right? So this is how you take the BA measurement. Then what about AP? So AP point is fixed 3 centimeters from the hymen in the posterior vaginal wall. So same, first you locate 3 centimeters from the hymen in the posterior vaginal wall, and then you ask the patient to strain. After patient strains, how much it has come down, measure it the value from the hymen. That will be the AP point. Similarly, BP point also. The most distal edge of the posterior vaginal wall will be the BP point. So anything should be taken in reference to the hymen, all the values, right? And then this will be the point C. So point C corresponds to the most distal edge of the cervix. So you measure that from the hymen. Okay. And then point D. Point D will be the posterior fornix, and this point D is not there in case of a hysterectomy patient, right? So once you have examined the patient, you know what to measure, you have taken the measurements, then you have to stage the prolapse after placing it in a grid. What is a grid? You already saw it here. So this is the POPQ grid, right? So this will be the grid. You have to note your measurements here, all the measurements. And then you have to stage the prolapse. So how do you stage the prolapse? So prolapse will be staged into total 5 stages. That is stage 0, where there is no prolapse. That is all the points AA, AP, BA, BP are at minus 3 centimeter, and C or D are less than or equal to minus TVL minus 2 centimeter. So that will be categorized as stage 0. And stage 1 will be stage 0 criteria are not met and the leading edge is less than or equal to 1 centimeter. And stage 2 will be when the leading edge is more than or equal to minus 1 centimeter, but less than or equal to plus 1 centimeter. That will be stage 2. And stage 3, where the leading edge will be more than plus 1 centimeter, but it will be less than plus TVL minus 2 centimeter. And stage 4, where the leading edge is more than or equal to plus TVL minus 2 centimeter. Okay. Right. So now, what will be the management of prolapse? So first, you know what is prolapse, what are the risk factors, and what are the classifications, and how do you take a history, examine the patient of a prolapse, do the POPQ, and stage the prolapse, and then how do you manage? So management is purely dependent. It is actually patient specific. So it depends on the factors like age of the patient is one thing, and has she completed her family, whether that is fertility, what is the desire for fertility, and what is her desire to preserve the uterus. So the management depends on all these factors. So basically you can divide it into conservative management and the surgical management. So in conservative management, you can tell them some lifestyle modifications. Now, what lifestyle modifications will suggest? You know that obesity is a risk factor. So you tell them to reduce the weight. And you know that the urinary complaints, the excessive caffeine or tea intake will irritate the bladder. So you tell them to reduce the caffeine intake and all those, and reduce weight. And do certain exercises also, specifically pertaining to the pelvis, that is the pelvic floor or the Kegels exercises. If along with the lifestyle modifications in conservative management, there is an option called as pessary. So we'll see what is the role of pessary also. And if all these measures fail, then you advise the patient to go for surgery, right? So at most important thing you have to remember is that prolapse is not an emergency condition, right? It's not an emergency. So if it is a mild to moderate or asymptomatic prolapse, they can be left untreated or managed with the pelvic floor exercises, like the Kegels exercises. And severe prolapse, grade 3 or something, you can still suggest them, if she doesn't want to get the uterus removed, you can still give them the options of conservative management with a pessary. But you should also tell them that they may require a surgery if the conservative measures fail. And as we have discussed, the decubitus ulcer can form. So usually it is because of the protrusion. There is a chronic protrusion leading to anoxia, and that leads to the ulcer formation on the surface. Okay, so that decubitus ulcer, it is ideal to treat it before surgery. So if the ulcer appears suspicious, then you should definitely go for a smear, biopsy, and colposcopy also if needed. And then prolapse reduction. So temporary sake, how do you reduce a prolapse? So you can do a vaginal packing, so which is soaked in ecreflavin and glycerin, because that reduces the edema. And this can heal the decubitus ulcer over a few days. So what additional treatment you can give? So you can give local estrogen creams also for 4 to 6 weeks. So this can also heal the ulcers, especially in the postmenopausal women. And lifestyle modification, Kegel's exercises, ulcer management. And now what is the role of pessary? So pessary is something, they are the vaginal devices to support the prolapse. So the pessaries can be used for anterior, posterior or apical prolapse also. So these are made up of silicone or inert plastic. So they are safe and easy to manage. So they are effective alone or in combination therapy also. So if you do a pelvic floor muscle training along with pessary, it is more effective. And with using pessary, you can see a improvement in the symptom score and quality of life also. And it can help in reducing the incontinence symptoms, right? And who is it useful for? So vaginal pessary, it is useful for a long-term treatment in the elderly women who will be unwilling for surgery or unfit for surgery also. You can give them the option of that is for grade 3 prolapse. You can advise a pessary treatment for such women, or temporary use in pregnancy and postpartum. If there is a prolapse, you can use a pessary. So how do you select a pessary? So pessary selection is of two types. The pessaries are basically of two types. So it is a support pessary and a space filling pessary. So example for a support pessary is a ring pessary. So and space filling pessaries examples are cube, donut and Gellhorn. So ring pessary, it has a spring mechanism and it supports the vaginal walls with the spring mechanism. So where is it positioned? It is positioned behind the pubic symphysis. So how do space filling pessaries help? So they maintain the position by creating a space between the vaginal walls. And Gellhorn is used in severe prolapse or complete procedentia also. And how do you evaluate the patient and placement? So success, it depends upon the patient's active role and ability to care for the pessary. How motivated is the patient and how willing is she to continue the pessary? And evaluation will help you to find out which pessary matches the patient and the anatomical needs. So in this picture, you can see these are the support pessaries, so which has a spring-like mechanisms, rests in the posterior fornix and against the posterior aspect of the pubic symphysis. So vaginal support results from elevation of the superior vagina by a spring mechanism. And space filling pessaries, so they maintain the position by creating a suction between the pessary and the vaginal walls. That is a cube pessary, and by providing a large diameter than the genital hiatus in case of a donut pessary, or by both mechanisms. So Gellhorn has got both mechanisms. So example is ring pessary. So here you can see the ring pessary, which is mostly seen in Indian cases. And this is a pessary with a ring support, right? And here Gellhorn pessaries, C and D, this is Gellhorn pessary. F is also Gellhorn pessary. And J is the cube pessary. This is the cube pessary. Okay, and this is the donut pessary. So what are the complications of pessary? So pessary can fall out. Usually insertion of pessary is an OPD procedure. So you should make sure that the pessary is in place. The fit is successful. The pessary fit is successful. So after putting the pessary, you should ask the patient to strain, pass urine, squat for some time. So she does all these activities to ensure that the pessary is in place, so that after going home, she doesn't find any problem. So there can be vaginal pain due to pessary, discharge or odor. There can be bleeding, and there can be urine leakage, the bladder leakage. Okay, these could be the complications. How do you follow? Now you have placed the pessary, it is fit, successful fit, and then how do you follow up? So you follow up the patient 1 or 2 weeks later and ask for any side effects, right, which are mentioned above, like any other complaint she has faced. And then you remove the pessary, clean it, and the vagina should be examined if there are any erosions, right? And then patient is happy, she wants to use it further, she's motivated full on. So then those patients are taught how to remove the pessary, clean it, and reinsert it, right? And then the second follow-up visit will be in 1 to 2 months, okay? And then once in every 12 months thereafter. And anytime the patient should return in case of problems like this, like the pessary falls out or vaginal pain is there and all of that. Okay, sometimes patients forget the fact that they have a pessary, which is called as a forgotten pessary. So sometimes that can lead to erosions, too much of bleeding. Okay, that should be taken care of. And we have discussed the conservative management. And as we know, you can advise them and tell the patient if they are ineffective, surgical management will be required. So what are the types of surgeries for prolapse? So they're basically categorized into reconstructive surgery, compensatory surgery or augmentation surgery, and another one is the obliterative surgery. So reconstructive surgery, where uh, the patient's endogenous support structures are used, and compensatory surgeries, the defective structure is replaced with a permanent graft material. Obliterative surgery, as the name suggests, so you close the vagina partially or completely. That would be the obliterative surgery. So here, this is a flow chart which tells you the surgical management or the repair procedures basically. So first, we know that it is a reconstructive surgery and it is an obliterative surgery. Let's see with the reconstructive surgery. So reconstructive surgeries for vaginal apex. Okay, that is the vaginal apex surgery. So if with concurrent hysterectomy, you are doing the hysterectomy at the same setting or she had had hysterectomy earlier. So what do you do in a reconstructive procedure? Okay. So if you want to use a graft or you want to use a native tissue. So if you want to use a graft or a mesh, so the surgeries are sacrocolpopexy, sacrocervicopexy, sacrospinous ligament fixation with a graft. If you're using a native tissue for a vaginal apex with concurrent hysterectomy or prior, then you can go for the uterosacral ligament suspension, sacrospinous ligament fixation, and iliococcygeus fixation. Right? This is the reconstructive aspect. And if you have to preserve the uterus for the reconstructive surgery, what do? So you do something called as the hysteropexy, right? So this could be with the graft or with a native tissue. So if you do with a graft or a mesh, so that could be the sacrohysteropexy and anterior abdominal wall hysteropexy. Okay. And native tissue, you can go for uterosacral ligament hysteropexy or sacrospinous ligament hysteropexy or Manchester procedure. And reconstructive procedure for a posterior vaginal wall repair, and this is for the anterior vaginal wall repair. So for anterior vaginal wall repair, you go for the anterior colporrhaphy, site specific anterior vaginal repair with graft or a paravaginal repair. For the posterior vaginal wall defects, so go for posterior colporrhaphy, site specific posterior vaginal wall repair with graft, levator plication, and perineorrhaphy. So here we understood all the reconstructive procedures. Okay. And here is the obliterative procedures. So where you obliterate the vagina. So obliterative procedures where you have to preserve the uterus. Go for colpoclysis without hysterectomy. With concurrent or former hysterectomy, go for colpoclysis of the vaginal wall or colpoclysis with the hysterectomy. Okay. So as we discussed, the posterior compartment prolapse, it involves the rectocele and enterocele. And the standard surgical procedure is posterior colporrhaphy. Okay. And site-specific repairs, what do? They target the rectovaginal fascia particularly. So if you do an overcorrection, it can lead to dyspareunia or defecator dysfunction in case of a posterior repairs. Okay. So perineal body, it is something which supports the posterior vaginal wall and the anterior rectal walls. So damage can widen the genital hiatus. For that, you do the perineorrhaphy, which restores the anatomy. So site-specific posterior repairs will target the fibromuscular layer in the posterior vaginal wall. Approach is just like hernia, identify, isolate, and repair the defect. Okay. And what is the treatment for? Now you have seen the posterior compartment and anterior compartment. So what about the uterovaginal prolapse treatment? So usually you advise them for the third degree or more cervical descent. If it is an older woman, you remove the cervix and uterus, which is nothing but hysterectomy. So it can be done vaginally, most commonly done vaginally. And if it is a young woman, you usually reposit the uterus and cervix in the normal position, which we discussed earlier, all the surgeries. And there is something called as sling surgeries, where you can advise these to the young nulliparous women for mainly for preserving the uterine preserving sling surgeries. So examples are Shirutko's abdominal sling surgery. It's a static kind of thing and uses a posterior sling. In Khanna sling surgeries, Joshi's, okay, Virkut's composite sling surgeries, and Sonawala sling surgeries. So, preservation of uterus in prolapse cases. So, first you have seen the sling surgeries, and there are other surgeries as well. So, mainly they are preserved in the young women who have not completed their families. So, example is a Fothergill or the Manchester repair, and another one is the Shirotka's modification of Manchester operation. Okay, and surgeries have to be dealt in detail. If time permits, I can go. And last is how do you prevent? How do you prevent the prolapse? So first thing, in order to know how do you prevent, you should know what are the risk factors, right? So the risk factors, you know that it is obesity, menopausal status, and the obstetric part. Okay, like if there is any damage, usually the first vaginal birth causes more damage than the second vaginal birth is what the studies say. So and occupational things. So first thing is by avoiding heavy weight lifting, and if there is any chronic cough or constipation, you should treat them. And obesity, so you should maintain ideal weight according to the BMI. And postpartum also, pelvic floor exercises should be done to regain the strength of the pelvic floor muscle. And otherwise, care should be taken during the delivery itself. Now a woman presents to you with prolapse maybe in the old age, but the point that you can avoid it during her delivery time itself is an important aspect. So you take care during the delivery, um, like give the perineal support properly, maintain the uh, give warm massages to the perineum during the labor process, so that the tears and the extent of perineal tears is minimized. So all these can help you in preventing the prolapse further. Thank you. And you have any questions, we can take it. I have few questions to ask also.
Recording stopped.